Hello, my name is Katharina Alamany. I'm doing my presentation on respiratory acidosis. First, we'll talk about what is respiratory acidosis. Depending on the source and direction of the aberrant change in hydrogen ions, deviations from the normal acid-base state are categorized into 4 categories. These subcategories include metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. A respiratory-related pH change is accompanied by aberrant CO2, which changes how the H2CO3 generates hydrogen ions. A pH deviation of metabolic origin, however, is accompanied by an aberrant HCO3 that results from an imbalance between the amount of HCO3 that is readily available and the amount of hydrogen ion that must be absorbed from non-carbonic acids and buffered by the HCO3. Acidosis happens when the HCO3 to CO2 ratio is less than 20:1. Any value less than 20 has a pH below 7.4, which is considered acidic. The rise of CO2 causes respiratory acidosis, which has the ratio of less than 20:1. Next, let's talk about compensations for this respiratory acidosis. Hypoventilation-related abnormal CO2 retention leads to respiratory acidosis. The increase in CO2 that results from the lower than normal CO2 loss through the lungs, caused by the hydrogen ions, to be produced from the source. Lung disease, drug, or disease-induced respiratory center depression, nerve or muscle problems that impair respiratory muscle function, or even simply holding one's breath, all can potentially cause respiratory acidosis. To return the pH to normal, this is where compensatory measures are used. More hydrogen ions are rapidly absorbed by chemical buffers. Because the primary issue is poor respiration, the respiratory apparatus typically cannot respond with compensatory increased ventilation. Hence, the kidneys play a key role in restoring respiratory acidosis state. They maintain all of the filtered HCO3 and replenish the plasma that knew HCO3 while secreting and excreting additional hydrogen ions in the process. As a result, the body's HCO3 reserves rise. The plasma HCO3 is doubled in the image that we see, making the HCO3 and CO2 ratio 40:2 instead of 20:2, as it was in the uncompensated state. The pH is once more the standard 7.4, since the ratio of 40:2 can also be equivalent to 20:1. Even though both CO2 and HCO3 are now skewed, enhanced renal conservation of HCO3 has totally made up for the CO2 accumulation. Here we have a study that involves two cases of ARF, or acute respiratory failure, in COPD, or chronic obstructive pulmonary disease, patients with severe respiratory acidosis and hypercapnic coma. They are successfully treated by NIV, which is non-invasive ventilation, in a pre-hospital setting. The cases that are used are examples of situations in which the choice between NIV, which is non-invasive ventilation, and ETI, which is the endotracheal intubation, is particularly challenging. The first patient is presented with ARF, or acute respiratory failure, induced by the intoxication of benzodiazepine, while the second patient has COPD, or chronic obstructive pulmonary disease, exacerbated, probably precipitated by NSTEMI, which is non-ST elevated myocardial infarction. Assuming that cardiac ischemia is not a consequence of severe hypoxia. Now, in both cases, we believe that the clinical improvement was entirely due to the NIV, or non-invasive ventilation, as it was the only effective treatment administered by the pre-hospital team. Indeed, no flumazenil was given to the first patient despite probable benzodiazepine intoxication, and the second patient was given aspirin and heparin, but no nitrates, diuretics, or inotropic medications. Although the study only had 2 patients, it does show some interesting ideas for further trials. So even if these 2 patients presented with ARF have different etiologies, their clinical picture at first is very similar. They both have a baseline advanced COPD of a pH of 7.25. Within the first hour, respiratory acidosis regressed, with a pH increase of 0.14 and 0.17 respectively. And neurological status also improved. In both cases, this makes it possible to avoid ETI. For the first patient, NIV was tried, and because of the potential harmful effects of ETI and mechanical ventilation in the context of advanced COPD. Conversely, while the second patient undoubtedly met criteria for immediate intubation ETI, the procedure was not performed to respect his will. Nevertheless, clinical improvement was even more spectacular in this case, with the patient recovering at almost normal levels of consciousness in approximately 30 minutes. So in conclusion, the COPD patients presenting ARF there's the NIV trial that could be considered even when relative contraindictions, such as an altered level of consciousness or a severe acidic acidosis, are present. They could regardless be considered for this NIV trial. In such cases, continuous medical surveillance is obviously mandatory, and physicians would be ready to perform the intubation of ETI should complications arise and the trial fail for that patient.